I think now we're going to hand it over to Nicole and Tharson, who are going to go into some of the more practical aspects and present a quality improvement project that has been going on for many years now here at Western, specifically in the osteoporosis clinic at St. Joseph's Hospital. While they're getting their slides up, I will give you an introduction to everybody, but I think I would be remiss if we didn't acknowledge Dr. Kristen Clemens, who really pioneered a lot of this work. And unfortunately, she couldn't join us today because she is in clinic. So just to introduce you to Tharson and Nicole. So Tharson is currently a third-year internal medicine resident at U of T, and he has been involved with this CKD Denosumab quality improvement since its inception. I think when he was in medical school, and he will be matching. He has matched to endocrinology at U of T, and will be a fully qualified endocrinologist in a couple of years. So I hope that this has put him in good stead. And also, I want to introduce you to Nicole McQueen. So Nicole is one of our nurses in our clinical investigations unit, and she's one of our specialist osteoporosis nurses. She's been a registered nurse now for 16 years, works within the CIU and with the Osteoporosis and Metabolic Bone Disease Program. And she has a particular focus on osteoporosis management for patients with chronic kidney disease, seeking improved approaches to better care delivery for this very complex patient population. So thank you both for joining, and over to you.
Okay, thank you everyone for the opportunity for Nicole and I to do this presentation. As Dr. Thane said, that this project has been kind of started since I was a first year medical student, so it's been a while now, and it's been a big part of my training. And Dr. Thane and Dr. Cowan have been huge parts of my growth as a medical trainee as well. So I really appreciate the opportunity. So this project has been a really collaborative effort. Sorry, it has been a really collaborative effort with the osteoporosis metabolic bone disease program at St. Joseph's, where we've been working with as a team with nephrologists, geriatricians, endocrinologists, trying to figure out how to use denosumab in a safe way in advanced CKD patients and dialysis patients. Yeah. And so I won't go too much in detail. I think Dr. Cowan already spoke a lot to like the problems that occur when you have kidney disease, and that as with like the role of the kidney in like bone homeostasis, you lose a lot of that as you progressively get kidney disease. You lose the regulation of PTH, vitamin D, hyperphosphatemia, and these different elements that are important to maintain bone. Now you go into this high turnover bone disease versus low bone turnover disease. And for both, what occurs is you get bone fragility, increased risk of falls, frailty, increased risk of cardiovascular events, fractures, and high mortality after the fractures. And so the goal for us is to try to understand more about this and how we can reduce the risk of fractures in the long term. And the fracture risk in the dialysis patients, particularly end-stage renal disease patients, is quite high compared to the general population. The dialysis patients face an estimated about fourfold higher risk of hip fracture compared to the general population. And it's not just the fracture, but it's what happens after the fracture, where the 1 year mortality rate in dialysis patients following a hip fracture, in some papers, estimated up to 30 to 50, anywhere from 30 to 55%. And so, with that being in mind, with the morbidity and the mortality of fracture, we tried to understand like what are the barriers to fracture prevention in dialysis, and a lot of it has to do with the complexity of the bone health. In dialysis patients already face a high burden of morbidity and also have a lot of appointments and clinic visits, and like a lot of times there's care fragmentation because they're already involved in so much care. And the fracture risk, honestly, it can sometimes be overlooked because of there's so many things going on. So it's understandable that that's not always at the forefront until a fracture actually happens. And we're limited, and Dr. Cowan touched on the different medications that are available, but we're limited by the fact that bisphosphonates are cleared by the kidneys. teriparatide can increase PTH, and romosozumab may be associated with cardiovascular events. So when it comes to denosumab, we understand because of its excretion, it is theoretically the safer option, and but there is a significant risk for hypocalcemia related to denosumab. And so our project, the objective was to create a standardized protocol. Like we discussed that these patients are complex, but we wanted to create a standardized protocol that involves the management and also the monitoring of protocols for patients with advanced CKD and those who are receiving dialysis. And so the idea was that to initiate this protocol prior to the denosumab therapy. And so our goal was to have reduce the risk of denosumab-induced hypocalcemia by 30% over 1 year. And we tried to include as many patients as we could, but we had an exclusion criteria where we didn't include patients who had undergone kidney transplantation. And so for the first step of our protocol, it was really to standardize the pre-treatment. So there's two main like phases of this protocol. I would say it's the identifying the patient that we believe we can optimize and give a standardized pre-treatment for with calcium and vitamin D supplementation. And then based on this optimization, then allowing them to then be prepared for the denosumab therapy. And so we implemented these initial intervention protocols with the collaboration with the nephrology team, the endocrinology team, and we looked at the early outcomes. And really, what we were able to see is that how we were able to figure out how we could establish this evidence-based like protocol with like the previous literature. And there is some literature that has been published talking about supplementation, how it may reduce the risk of hypocalcemia. And so trying to standardize calcium carbonate and activated vitamin D dosing regimens and adjusting individualized dialysate calcium concentrations and really setting patients up for success with improving their baseline serum calcium levels. And I think Dr. Cowan showed this great slide where it was in the first month, the risk of hypocalcemia is significant. And so we tried to create a monitoring schedule that we actually are benefited by the fact that patients who are on dialysis come into clinic so often. So then we're able to monitor them in a easier way than we would for other patients who aren't in care settings as much. And we were able to create the communication templates between the different care partners in order for us to make sure that the coordination was successful. And so the second iteration, we're able to optimize calcium supplementation relative to the dialysis sessions to making sure that patients are not just taking supplements, but also adjusting their dialysate. And we also, the adherence was a big piece where we really did try to emphasize that the calcium and vitamin D supplementation was taken on a daily basis. And this was important because when you look at the previous literature, one of the biggest, I think, gaps in the literature is that we don't have an understanding of how many of the patients who were getting hypocalcemia were actually taking supplementation versus how many weren't. And so the laboratory monitoring and safety parameters we had was that in week 1, we looked at the metabolic panel with like calcium, phosphorus, vitamin D, and we then would supplement, ensure the calcium was above 2.15. And then once they were above that baseline level that we felt was safe, we repeated the calcium phosphorus measurements after the denosumab injection after week 2. And so the week 1 was the injection, week 2, and so those first 2 weeks were critical for us, and then we had monthly follow-ups. And so with that, this is some of the baseline data. So we had a few patients for both cohorts. So the pre-implementation were patients who didn't before they received denosumab or who didn't receive denosumab and how their calcium levels looked and their baseline calcium levels. And then the post-implementation, we had the dialysis patients who actually received denosumab and looking at their vitamin D levels and calcium levels before they received the denosumab injection. And so we were able to see that in patients who received denosumab, specifically dialysis patients, um, the post-implementation, we were able to show that hypocalcemia risk was reduced, and our target of having patients achieving zero hypocalcemia events, zero symptomatic or severe hypocalcemia events were achieved. So we did, as I'll go back a slide, so we did see that there was hypocalcemia in patients on dialysis, but they were never in the severe range or symptomatic range where we were concerned. And we reached our target of 30% target risk reduction. And so what we were able to show early on, and Nicole will touch more on this as well, is that if we're able to identify the right patients, optimize the patients, we could prevent the risk and reduce the risk of hypocalcemia due to denosumab.
Thanks, Tharson. So here in the clinical investigations unit, we see the non-dialysis patients with chronic kidney disease. So with our protocol, we took a look at it and we're noticing that 25% of the visits resulted in hypercalcemia, which is a corrected calcium of greater than 2.5. We were noticing that it was happening in the blood work the day of the injection, and also with some of the patients at kind of the 3-week post denosumab mark. So we thought there could be some room for improvement there. The other thing was nursing staff. As our program grows, we're getting more nursing staff, and we were wanting a more standardized calcium supplement protocol. And then finally, we thought that there could be some improvement with the liaising between us and primary care providers, because we do have a few patients that receive the denosumab with our CKD protocol through their PCPs because of either ambulatory issues or travel. They're from far away. So now we contact the primary care providers ahead of time to make sure that they're aware of our protocol and comfortable with our protocol, and then they can decide whether they want to go ahead with it or if they would like us to continue with the protocol. So the patients that we included in this were non-dialysis patients with an eGFR of less than 45 who were prescribed denosumab by one of our physicians in the osteoporosis and metabolic bone disease program at St. Joseph's Hospital. And we collected our data from January 2023 to June 2025. This is the data that we had collected. And just a couple things to note from that data. So with malabsorption, we noticed 44% of the patients had malabsorption issues. So this we brought forward with our newer protocol, which I'll talk to more when we look at the protocol. The other thing to note was the median eGFRs appeared lower in the hypocalcemic group. So the normal course, which are the people that we didn't have to adjust their calcium supplement at all, their eGFR, the median was about 30. With hypocalcemic patients, the median eGFR was 22, and hypercalcemic patients was 27.5. So it was just interesting to note we were seeing that. And magnesium seemed a bit lower in the hypocalcemic group. And we actually found, nursing-wise, that it was harder to increase their calcium through oral supplement if they had a lower magnesium level. We really struggled to correct their calcium. So this is we call it now our old protocol. So this was for the patients from January to June of 2025. So we used to, 1 week prior to the denosumab injection, increase their oral calcium supplement. And this was using kind of like our best educated guess, especially if they were new patients. And then if they had already had denosumab in the past, we would go back and look at their old power chart notes and see what worked for them in the past. So this is why we kind of decided that for nursing, we needed a more concrete calcium supplement so that we were all on the same page with that. As well, our instructions for the oral calcium supplement, we now know were a little bit vague. And we found that the number of patients that were coming through with corrected calciums of greater than 2.5, we could possibly decrease this by not pre-treating them a week before. That way they weren't hypercalcemic for longer than they needed. And oftentimes, sometimes patients would have to reschedule their appointments. So they had been on the supplement for a week and then needed to change their appointment. So then we'd have to stop it and then restart it. So the day of the injection, we would obtain their blood work. And at that time, it was just calcium albumin. And then we would calculate the corrected calcium. We provide the injection and the patient instructions. We also then collected either weekly blood work for 4 weeks or biweekly blood work for 4 weeks. And at this point, we also started noticing patients around week 3, some of them were hypercalcemic at greater than 2.5, and we weren't stopping the extra calcium supplement. So we saw this as a reason that we could make some improvements. So now we call the patients 2 weeks ahead of time to get blood work drawn. That way we can better supplement them for the day of. Also, sorry, Thurston, can you go back a slide? Thanks. So 2 weeks prior, we get blood work, and now we include magnesium and 25 vitamin D if they haven't had it in the past year. And then the day of the injection, we now start their calcium supplement. And then this way it ensures if they have to reschedule, they're not having that prolonged calcium supplement increase. And it ensures that all the nurses are on the same page for the calcium supplement. We also included in our instructions now, especially if they're over 1,000 milligrams a day of calcium supplement, we break it into BID or TID doses to help with the absorption. And also we educate them to take it apart from meals, just to help also with the absorption. We added magnesium to the blood work. So then we can look to see, has this actually been affecting how our calcium supplementation is working? And now we stop our calcium supplement if by week 3, they're hypercalcemic, because we know, just looking back at our past patients, usually by week 2, that's their highest risk of hypocalcemia. So if by week 3 they're too high, we know that it's safe to stop. They're not going to fall any lower. Also, we've changed so that if they've had 2 injections of Denosumab under CKD protocol that were both normal calcium throughout, we didn't have to adjust their extra calcium supplement. We changed them from weekly blood work to biweekly blood work, just to save them some trips to the lab. And this is the calcium supplement table that Dr. Clemens provided us. This is the one that we use here for the past since November. So if it was 1,500 milligrams or more, we were doing TID. 1,000 was BID. And then we contact the physician if it's less than 2.15, and then we can stop it if it's week 3 or 4, if it's greater than 2.5. So we've had 9 patients go through the protocol since November. We're still collecting all the same data that we were before, except this time we're also comparing it to the old protocol. So was this one hypo, normal, hyper, and then what were the past protocols, just to see if we're making any difference or if it's the same. We are hoping we can get everyone normal calcium, but it's not always possible due to comorbidities and compliance. And we've also been seeking feedback from patients about how it is, how easy it is for them to follow, how hard it is for them to get blood work ahead of time. So far, we've received positive feedback, but it's still in the very early stages. And in summary, Denosumab can preserve BMD in advanced chronic kidney disease and dialysis patients, but it's associated with hypocalcemia. Denosumab can be prescribed more safely by ensuring normal calcium, magnesium, and 25 Vit D at baseline. prophylaxis, care coordination between family doctor, bone specialist, nephrologist, close monitoring, and of course, quality improvement is essential to good clinical practice.
Thank you so much, Nicole and Tharsan, for presenting this. I know this has been a lot of work over many years, but I do think, or I feel like this is one of the most significant pieces of work that we've done through the metabolic bone disease, because we've opened up treatment to so many other patients who may have otherwise not received treatment in the past. I'm just going to open it up to see if anybody has any questions on anything that Tharsan and Nicole presented, particularly to see if this may be relevant to the areas that you work in, and if that's something that you are interested in to know as well. Hi, Lauren.
Hi, thank you so much. This has been a really great session. Oh, sorry, I'm getting feedback. Can you hear me okay? I'm in rural internet land.
You're good now, yeah.
Great, thank you. Thank you so much for talking through that. That's really interesting work. I work as a nurse practitioner in geriatrics now, but my first love and my whole first part of my career was in nephrology, so this was my favorite session so far. Just thinking about, so I work in a rural area now, and I see this really good, important work that you've done with kind of the dialysis units locally. And then, of course, Nicole, you kind of outlined how you were working with the primary care providers to make sure that some of these protocol opportunities were available for folks that can't travel and that sort of thing. Just thinking about the satellite dialysis units and the folks that are being cared for, removed from some of the larger settings. Is this something that has been trialed with those patients as well? Maybe I missed that, or is it in one of the future PDSA cycles?
I can.
Sorry, go ahead, Dr. Cown. No, go ahead.
So I can say from my experience, we have done it in some satellite units. We're very fortunate because we have dialysis nurses who are excellent in the satellite units, who are really good at, great, we need to do the calcium. And then we have nurse practitioners that kind of manage things remotely. So location for us hasn't been, in the dialysis population, location has not been necessarily too big of an issue, because we're lucky that we are able to do blood work up to 3 times a week, and we get turnaround in a pretty good time frame, so that we can adjust things for the next dialysis or adjust their calcium supplementation.
Great, thank you.
So while we wait and see if there's any other questions, can I just let everybody know, I saw that Ellen has put the evaluation in the chat. So if you get a chance, please take the opportunity to do the evaluation. Lauren, if you think this is the best session you've ever heard, please write it on a form. It's really helpful for me. Andrea, can I ask you, and maybe Tharsan, you can give a little bit of your opinion as well. Fragility fracture and chronic kidney disease and the uptake of this sort of thing, do you know what the general feeling is? Is this still something that's relatively new within the nephrology sphere, up and coming? And is this something that other centers you feel are willing to adopt in the near future?
That's a great question. And I think, Tharsan, your experience at a different center will also be useful, because I know you've had some experiences. I think that it is highly provider dependent. I do think that there's still a lot of nihilism in the nephrology world, where people kind of go, well, what am I going to do about it? So why would I even, think about it? And dialysis patients are complicated. They also have cardiovascular risk, and, they've got their foot ulcer, and their diabetes is poorly controlled. And, often there's a lot of other competing priorities, right? And I had a nephrologist say to me, like, how do you think about bone health? Like, I have 6 other things that I have to think about before I get to that. So I do think, perhaps I'm biased because I'm in this area. I do think there's certainly interest in it. And I will say, Tharsan and Nicole, your work in this area, when I do tell nephrologists this, they're always very interested in it, because I think a lot of nephrologists have had very bad experiences with denosumab. The people who are on it through their family doctor, and we never know until one day they do their preclinic blood work and their calcium's 1.5, and you think, oh, and that's happened to every nephrologist I've ever talked to. So I do think that there's a lot of interest, especially in the QI portion of things. But I do think that there are a lot of hearts and minds that need to be changed yet, and a lot of people who are very skeptical, especially of denosumab, because of those bad experiences.
Yeah, and I can speak a bit about my experience. Like I'll say that I think initially being at Western, I was very spoiled on like how cognizant we are about we're thinking about preventing fracture and in the dialysis population. And I think like Dr. Cowan touched on, I think because there's like so much complexity around it, and reality is like you real like a lot of us are like our practice as much as we are very like try to be very evidence-based. I think our clinical experiences also like have a big influence on how we react to choosing which medication. And people have had bad experiences with denosumab, and it's like and a lot of the studies that have shown a lot of the studies that have shown that like things like it increases cardiovascular risks or like the atypical femur fractures. I think those things kind of sit at the forefront of our minds when we think of denosumab. But what the goal has been with this project and with the research is that um, there probably is like there is a patient population that if we optimize and if we kind of think about carefully, we can prevent the fracture risk. And I think the next steps, like a project that we're hoping to work on soon, is getting an understanding of like what's the comfortability of like fracture prevention in general and like dialysis units, what kind of things are getting done, and how can we kind of go from there and try to figure out like a standardized way to like create a simplified protocol for a very complex patient population. So I think it's very center dependent, and I think it's experience dependent. But and I would say like to echo what Dr. Cowan said, I think I think most people do not like denosumab, but I think that I like and I'm biased in that I have worked with great people who have shown me the other side of things. So hopefully, being here, I'll be able to change some minds over the next few years.
Maybe this is going to be the start of a revolution.
Maybe.
I remember going to a conference. I'm going to date myself and say maybe 15 years ago, and it was a bone conference. And the person asked, how many of you have interdisciplinary team meetings between your orthopedic surgeons and your geriatricians? And this was in the UK, and virtually everybody put their hand up. And he said, how many people have interdisciplinary team meetings between your osteoporosis specialists and your nephrologists? And 0 people put their hand up. And the fact that you're, publishing this work, bringing awareness, and very importantly, providing clinical protocols on how to implement it, I think is super important. I think I am allowed to say this, but Dr. Clemens and I are currently working with Dr. Joanne Ho from Jerry MedRisk, hoping to be able to create an osteoporosis and CKD protocol through the Jerry MedRisk program via an e-consult service. So this is not up and running yet, but it is in the works. And once that's established, happy to let you all know. Any other questions for Nicole or Tharsan or Andrea today? If not, I think we can leave it there for today. Thank you again to everybody for joining for the first Echo Orthogeriatrics session of the year. We hope to see you again in a couple of weeks. At that time, Jenna Vanden Heuvel is going to be talking about the National Surgical Quality Improvement Program and how you can leverage it to improve hip fracture care at your center. So thank you very much. Bye.